Performance status is a very important prognostic factor for us, and it also kind of defines how we approach patients. This gentleman is a good performance status, an ECOG performance status of 1. So the patients who fall into the 0 to 1 category, which are either fully ambulatory, asymptomatic, or fully ambulatory, doing all their activities of daily living and having, not too much of a symptom burden, those would identify the PS0s and the PS1s. Those patients are suitable for platinum-based doublets. Those are the patients that were included in the pivotal trials for bevacizumab, and so those are the considerations that I would do or have in that patient population. Performance status 2 patients are reasonably common. These are patients who have a greater symptom burden, are requiring some help with their activities of daily living, but are still spending more than 12 hours out of bed during a 24-hour period. Those patients, I tend to use platinum-based doublets if I think that their performance status is being driven by their disease. And that's a very hard assessment because sometimes patients with lung cancer have many comorbidities. Lung cancer is still linked to smoking. Patients can have heart disease, they can have COPD, and sometimes these comorbid illnesses may impact their performance status. The most common reason to impact your performance status is your disease burden. So if I'm convinced that it's disease burden in the PS2 population, I will use chemotherapy, doublets in that setting, because I want to give them the optimal chance to have a reduction in their disease volume to improve their symptoms and hopefully their performance status. If you're convinced, I often ask the patient, well, what were you like a year ago? If you're now diagnosed, are you any different now than you were a year ago? You have COPD, you have heart disease, you have this, that. And if you're the same a year ago, then I'm thinking it's really probably not the cancer that's driving their performance status. Maybe it's the comorbidities. And chemotherapy is not going to improve your comorbidities. So many of those patients, I will generally use monotherapy or single agent therapy for that population. The PS3s and 4s, PS4 is a bedridden patient. A PS3 patient is a patient who's quite symptomatic and spending more than 12 hours in bed. Those patients, we don't know that there's any benefit from chemotherapy, and there's a real concern that we cause harm in that population. So if you look at guideline recommendations, NCCN, or any other guideline organization, for the PS3s and 4s, it's best supportive care as the standard of care. Both age and performance status are important. Age is a relative number. There are certainly some very healthy, active 78-year-olds, and there are some very sick and not very active 58-year-olds. So it's a consideration because I think the older you are, there are 2 things that factor into my thinking about this. One is the older you are, the more likely you are to have other medical problems and comorbidities. That's just a fact. Secondly, the older you are, the less reserve you have. So, giving treatments in that setting, you have to be aware that there may be, or you are running the risk of having more toxicity because of the reserve of that particular patient. Again, there's not a cutoff. I've treated patients in their early 90s with chemotherapy. But these were special patients. It's not the average 90-year-old that I would treat. Also, I think as we age, we have different preferences. Everything we're talking about in stage 4 disease is treatable if you're a good performance status, but not curable disease. So trying to understand the goals of the patient and the patient preferences, what do they want to get out of treatment? What are they looking for? Is important. And I find that as patients age, their preferences and goals may be somewhat different than if you're, say, 50 years old. So I think that's another area where age factors into it in terms of what patients want for treatment and what they're willing to take for treatment.